Hey everyone. This lecture is going to cover data collection and loss of data, and specifically what we're concerned about in randomized controlled trials are attrition and detection bias. So the lecture objectives refer to learning objective 12, which is to critically appraise a randomized controlled trial for bias and consider any bias effects on interpretation of results. Specifically, our objectives in this lecture are going to be to define and discuss detection and attrition biases and potential mitigation strategies. So just to review, the key elements of RCTs, and those are that you are intervening and that we're randomizing the intervention. So the intervention distinguishes RCTs from prospective cohort studies. So instead of just identifying people based upon their exposure status, we're actually creating the exposure, which is the intervention, and then we randomize people. And so the goal of randomization is to minimize bias. And so when performed correctly, randomization should address both known and unknown confounders and sources of bias, as well as measured and unmeasured confounders and sources of bias. And I think that that's really a key point, is that not only are we, there's certainly things that we know are potential confounders, but there's things that we are definitely not aware of, but randomization should handle those as well. And there's confounders which we can measure fairly precisely. But even if there's things that we know about, we may not always have good ways to measure them. But again, randomization should address those as well. And so that's why randomization is such a important tool and really the key aspect of RCTs. Thus far, I know that we've talked about selection and performance biases. Just to review, selection bias refers to systematic differences and baseline characteristics between the two groups being compared. And this is typically, again, due to either incomplete or unconcealed randomization. And then performance bias refers to systematic differences in care provided to study participants apart from the intervention. So this is often a result of when you know what treatment arm, so again, kind of unblinded, intervention status, and that people in one arm may receive different care compared to people in the other arm. But this is not care specifically related to the intervention, but care outside of the intervention. So today's topics, this lecture's topics are detection and attrition bias. If we look at our schematic here of a RCT, you'll see we identify our target population here at the top. People are allocated, so randomized to either an intervention and a control group. Okay, this is where selection bias may be introduced. Okay, if this randomization is incomplete or ineffective, people are then exposed to the intervention or not exposed to the intervention, and this is when performance bias can have play a role. Again, when people are receiving care, apart from the intervention, but that is differential between the two groups. And then the two things we're going to talk about today. So you'll follow people, right, to see if they have their outcomes, the outcomes of interest, and if there's what we call attrition bias will occur if there's differences in withdrawals from the study or missingness of data, and then detection bias if there's systematic differences in how outcomes are assessed between the two groups. So we're going to talk about detection bias first, even though it's the last part of that figure. Again, we're referring to differences between comparison groups, systematic differences between comparison groups, and how outcomes are assessed. This typically occurs as a result of knowledge of what intervention arm that people are on, and you can either consciously or unconsciously have this can unconsciously or unconsciously affect your outcome assessment. So the primary concern in detection bias is with respect to subjective outcomes rather than objective outcomes. And so subjective outcomes, we're talking about things where the assessor is making a judgment call regarding whether or not someone had the event, or for patient-reported outcomes are also typically subjective outcomes. And so these are susceptible to detection bias. The primary mitigation strategy here is blinding. Okay, and so this is something that I know you all have heard before. And so you really want to blind anyone who will be involved with the outcome assessment. And so who should be blinded? Well, study participants are typically are often blinded. Sometimes you'll read about open label studies where people know what they're taking, but often study participants will receive the intervention or a placebo to help control for this. Healthcare providers that are seeing these patients, and then of course the outcome assessors and the data collectors who are actually determining these study participants' outcome status. And again, the reason why we do this is because unblinded outcome assessors or data collectors are more likely to do things like repeat measurements if something's abnormal, provide encouragement for performance testing if they know people receive the intervention, or just differentially assess these subjective outcomes. And again, even if you're not consciously doing this, you can, unconsciously or subconsciously do this as well. As you can imagine, blinding is not always an option for some studies. Sometimes you just can't blind. But during your appraisal, what's critical for you to do is you have to kind of assess whether or not there was blinding, and then determine how that when there's not blinding, how that impacts the study. And some things that you should look for are whether or not they had a priori criteria for outcome assessment. So they shouldn't be like defining these things at the time of outcome assessment. There should be a protocol that explicitly states how these outcomes should be defined and assessed. There should be good training for study team members to apply these criteria. There's a lot of talk about kind of the fidelity of both the intervention and also of outcome assessment, for making sure that this is the same across study sites, and then also the same for the first participant to the last participant in a study. So you really want to ensure that you're doing that there's consistency there. And some studies have utilized what's called central adjudication, which means that outcome assessment is actually done by independent experts, and so people that actually aren't part of the study, and they'll just receive whatever the data on whatever those criteria are, and they'll make the decision. So when you're doing your appraisal for detection bias, you're going to categorize this as the risk of bias as either being low, high, or unclear. The guidance for this is in this table. So for low risk, there's either blinding of assessors, which was either they ensured the blinding or was unlikely to be broken, or if they didn't have blinding, so this can still be low risk, but if not blinding, was unlikely to have affected their outcome status. And the best way for that is to have objective outcomes, but sometimes that's just not part of your study. High risk is when outcome assessors have the ability to identify whether or not people are receiving the intervention or not, or if it's not possible to blind people, or the blinding could potentially be broken fairly easily. And then as I think you'll see, often it's not clear. It's either just not described very well, or there's insufficient just information for you to be able to make this decision. How common is detection bias? So, as we've discussed, there are studies that will review, published trials often in the large general medicine journals. And so in this study, in this review of 258 published trials, they looked at whether or not the primary outcome was blinded and whether or not this differed according to the outcome or assessor type. And 106 trials, so less than half, 41%, were double blind, and 152 or 59% were partially blinded or just fully open label. So you'll see, so sometimes again, that it's not always going to be possible, but you really want to ideally blind, and again, just think about what types of bias you may be introducing in non-blinding. So I think this is fairly intuitive to most people, so we're not going to spend a ton of time on it. But just to summarize, so detection bias occurs when there are systematic differences between groups and how outcomes are assessed. The primary concern here is with respect to subjective outcomes. The mitigation strategy or control for detection bias occurs at the design stage with blinding of participants and study staff, and it continues, throughout the study in the sense that you're trying to ensure that blinding remains in place. Okay, but as I just showed you, many trials are at least partially unblinded and at risk for detection bias. So the other topic of this lecture is attrition bias. And this slide always cracks me up because this guy's kind of jumping out of line here. And so basically what we're concerned about here is loss to follow-up. So attrition bias occurs when there are systematic differences in how patients are lost from a study and or how their information is missing from a study. Okay, so loss of data, loss of participants, or loss of or missing data. And so, again, we're concerned about things like dropouts, or what we sometimes are called non-completers, or people that are lost to follow-up. Those aren't all the same thing. So, people that are like consciously dropping out of a study versus just people that for whatever reason are not able to be contacted, or just other reasons for why there may be, just missing data. So, attrition is, as you can imagine, potentially really destructive to studies, because it can certainly affect, like, the randomization process and trying to basically decipher whether or not, what's actually responsible for the outcome. So are people dropping out because of, are the prognostic factors that you were previously hypothesizing, really, the cause of this outcome, or is it because your groups are now different due to some differential loss to follow-up? And, the other concern that happens with attrition is that, if people are dropping out, then when you created your study, you tried to create a study sample that was representative of the population that you want to then apply your findings. And is that still the case if there's a lot of attrition? How common are dropouts and missing data on RCTs? So kind of a similar review of as was described for detection bias. So they looked at 71 RCTs published in I believe the same journals. And so 6 trials reported, or 10% of these studies reported having no missing data. This was looking at quality of life outcomes. But 20 trials, or a third, actually reported that either 10% or less had outcome data missing. And 11 trials reported that between 11 and 20% of outcome data were missing. And then another 11% reported that more than 20% of outcome data were missing. So this is potentially real problems. And these are trials, again, that are published in some of the really the top journals. So you can imagine that studies in other journals would probably actually be worse. meaning having even more missing data than these studies. So, I referred to some of these things earlier. So what are some common attrition examples? So again, people that either stop early or miss an outcome assessment appointment, or often outcomes are assessed because people are completing, diaries or questionnaires, and that these aren't like fully complete. And then there could also just be, things that happen, like, records are lost, or, you don't know what happened to people because they're excluded from the study, or people have what's called non-adherence. Okay, so they either cross over, so they're not supposed to be taking, they're randomized to the control arm, but they somehow end up taking the intervention medication. There's contamination, or they just know that people didn't really just adhere to the drug schedule or the dosing or whatever. So there's a couple things that you can do to try to mitigate attrition bias. The first is in the design stage. You've seen this a lot when we talk about kind of different ways to either control for confounding or control for this. Is that there's things that you can do in the design stage, and then there's things that you can do in the analysis stage. And in the design stage, the main thing that you want to do is try to minimize attrition. And so you want to try to prevent dropouts and prevent missing data. And then as we'll talk about in the analysis stage, you do something called intention to treat analysis. So in the design stage, again, you want to try to prevent loss to follow-up or missing data. And the first thing that you should always do, and so that you really have to do nowadays, is have just a rigorous and sound study protocol. And now you're basically required to kind of submit this to clinicaltrials.gov and make sure, and this goes through just tremendous review to make sure to ensure safety for the participants, which is paramount. But also just that your methodology is rigorous, and that you have you're going to be able to consistently apply the study protocol across sites. You want to ensure good communication between study staff and participants. You want to make sure that when people come into clinics, that they're able to get there and get their outcomes assessed. Okay, and this is often a problem, especially in I think some kind of resource in some environments where there's just fewer resources or fewer clinics, our people are going to have issues with transportation. So you need to kind of consider all these things. Often for some of these studies that really require people to really be on board, you will often provide incentives to continue in studies. And so these are typically kind of financial incentives. But you also just want to ensure that the study is relevant to the people that are participating in it, and so that they have some, they see some intrinsic value in participating in the study. So that's what you want to do in the design stage. And then the analysis stage, what we're going to do is something called intention to treat analysis. And so you see here the town crier is announcing, so if randomized, then analyzed. And so the intention to treat principle is that all randomized patients are analyzed according to their randomization allocation. So even if you know that people, even if there was dropouts, or if the people were non-adherent or crossed over, there's some other type of protocol deviation, you still analyze them according to the group to which they were randomized. And we'll talk about why we do this. And the most important reason why we do this, and this is why I brought this up in the first slide of the lecture, is that by using intention to treat analysis, you're preserving randomization. Randomization is the single strongest aspect of the RCT to minimize bias. If you remove that, and if you don't do intention to treat analysis, you are then going to break randomization, and you are going to lose all the benefits of randomization. And then just some other kind of practical reasons why intention to treat analysis makes sense, since it may not initially make sense, is that this actually approximates kind of real world circumstances where patients are often non-adherent to their medications. or to, you know, the whatever treatment they're on. One note is that, and we don't really talk much about non-inferiority trials in this class, but, you know, really you want to use intention to treat for binary outcomes, okay, in what we call superiority trials, where your, you know, alternative hypothesis is that the intervention is going to be superior to either the control arm, which is either a, you know, placebo or current standard of care. And the reason why I'm telling you this is because in non-inferiority studies, where you're basically just trying to show that whatever your experimental therapy is, it's just not worse than the current therapy. Intention to treat can sometimes bias non-inferiority trials into showing non-inferiority, because it can make the treatment and the control arms look more similar. So just remember that, you know, intention to treat is just most appropriate for superiority trials. One thing that I suspect you might be wondering is then, well, how do we know what happens to people, or how do we assign an outcome then, or how do people have an outcome if we don't know what happened to them? And so there's different ways to impute for the missing data that happens when you want to analyze all people in your analysis, and that you actually assign a value to them. And so there's different ways of doing this. Excuse me. Most of these kind of further discussion of these is kind of beyond the scope of this class, but just know that there's different ways of doing this that you may see. So they'll sometimes use basically what are called mixed effects models, which are kind of something that you can use statistical software for to assign a value to people. Often you'll also hear about what's called last observation carried forward, which I think is fairly intuitive what that means. But basically, you just look at the last data that you have, and then you move, and then, you know, people continue to have those outcomes, which doesn't work for everybody. So could cause issues if you're like looking at things like degenerative diseases. And so there are some methods for how to impute this information, and studies should tell you how they do it. And so you should kind of look for that. But, you know, again, I think it's kind of beyond this class to exactly understand all aspects of that imputation. So this is just an example which kind of looks at the effects of either not using intention to treat analysis. And so this is a hypothetical study of people randomized to either aspirin or surgery and aspirin to look at stroke prevention. And so you have 200 people, and 100 are randomized to each arm, and there's a 1 month period that you have to wait before you can actually have the surgery. So that's what's going on in this upper arm. So again, 200 people rather with cerebrovascular disease. They're randomized to either surgery plus aspirin or aspirin alone. In both groups, and the underlying hypothesis here, the underlying assumption is that surgery actually doesn't help. Okay, and so, you know, here you have 10 people on the surgery arm that actually have a stroke before they even have surgery, and then the other 90 people have surgery. You follow them forward for 1 year, which is indicated here. Another 10 people have surgery, or have a stroke rather, over the course of that follow-up period. And in the aspirin group, you actually have a very similar pattern, of which 10 people have kind of stroke early, and then another 10 have it kind of later on during the follow-up period. So, so I just explained this, but here, okay, so here again, these 10 people in the surgery arm have stroke before surgery and 10 afterwards. And if you do what we refer to as a per protocol approach, which basically means that you're analyzing people according to exactly what you know happened, you end up excluding these first 10 people because they actually never had the surgery. And so as a result, the per protocol incidence of stroke is just 10 over 90, or 11%, and in the stroke group, it's 20 over 100, so 20%, or 0.12, yielding a risk difference of 9%, or absolute risk difference of 9%. Okay, but what happens is that this actually favors the surgical group. If we actually allowed these 20 people in, who, in this example, surgery actually doesn't, is not beneficial. Okay, but because we excluded these people, it makes it look like surgery is better, when in fact it's not doing anything. All these people just didn't have surgery. You're just excluding the people that never bothered to have surgery. So, again, I think this example is, so this is may seem a little bit confusing to you, but here the underlying assumption here is that the surgery is not effective, but we're making it look like it's effective because we're excluding these people despite that they were actually randomized to the surgical arm and didn't have surgery. So in the intention to treat analysis, if you include everybody, you'll see that there's actually no difference between the surgery and non-surgical groups, and surgery does not appear to have this added benefit. So in your appraisal, there's a couple of things that you want to make sure that you look for. You want to look in your, so you want to always look for a flow chart, which we call a consort diagram, to basically see, kind of how people, everything from when people were randomized and then followed, and then who was lost and what the attrition was, and if it was different between the two groups, was there any crossovers, were there any other exclusions? Just to be clear, we're, intention to treat is the preferred analysis to minimize bias and to preserve your randomization. So you want to really verify that the outcome analysis does include all people that were randomized. Okay, you do want to look at, in this consort diagram, attrition and whether or not you can look at total attrition, which is just, so in both groups was just the total number of people who were lost. Was it really high? Was there a large number? And then you also want to look at differential, differential attrition, and whether or not it was different between the two groups, and why. What were the causes for the attrition? Were the reasons similar, or was it something that might be related actually to the intervention, like an adverse drug event or the treatment being ineffective? Okay, so here's just a kind of a consort flow diagram. So you assess people for eligibility, people get excluded, that's fine. But then here you have your randomization. And so once you randomize people, then you want to basically see what happens. And so people are allocated to the different groups, and then they're, during follow-up, who's lost to follow-up, why are they lost to follow-up in the two groups, and then kind of, who was analyzed, and if people weren't included in the analysis, why not? And so this is from a trial on lisinopril for migraine headaches, and here they actually have this kind of consort figure, which is great and what you want. Okay, but note that there's they start with 60 people here, they randomize 30 to each group, and then people kind of complete the study, and then they actually look at then 55 people, even though there were 60 initially randomized. And so, and they call this explicitly, they say that they have intention to treat analysis of 55 people, even though they actually randomized 60 people to the different interventions. So is this a true intention to treat analysis? Okay, and then you can go through some of the other questions. And so we're just going to kind of skip ahead. So no, it's not true intention to treat analysis, because they actually excluded people who discontinued for different reasons. Okay, so this is actually a per protocol analysis. Okay, what is a total attrition? Well, we know that there was started with 60 and now there's 55, so it's 8%. And was it different between the two groups? And no, not really. Okay, so there was 3 in one arm and then 2 in the other arm. So not majorly different. But this was not, even though they call it intention to treat analysis, it's actually per protocol analysis. Sometimes you'll see studies that say that they did other things than intention to treat. So they'll do something. They'll sometimes say that they did like modified intention to treat, or what we already talked about, which is kind of this per protocol analysis or as treated. Modified intention to treat. I still don't exactly know what that means. Sometimes people will kind of justify that why they excluded people, but I think you should be pretty skeptical about that. Per protocol analysis, we already talked about why that's not something you want to do. Sometimes this will be considered appropriate if your primary analysis is safety. Okay, and safety, typically we're in trials you're always looking at both safety and effectiveness. And so effectiveness is your treatment effect, but then you're also looking at things like adverse drug events and drug those types of things. And so per protocol analysis may be okay for safety analyses, but it's not how you want to evaluate your specific intervention. And similarly, as treated is the same issue, but again, you're losing your randomization here, similar to per protocol, and so it's not something you want to do unless, again, you're looking at safety outcomes. So when you're doing your appraisal, what are some of the things you should be looking for? So you're going to first look at whether or not there was, a high dropout rate. So what was the overall attrition? And basically anything near or above 20% should be fairly concerning and could really affect your study power. As we've talked about several times, you're going to do an a priori. Okay, so before you do your study, especially for an expensive clinical trial, you're going to do some type of power calculation that says how many people you need to see, the difference that you're interested in. So, if you're losing like that many people, you should, you're probably pretty concerned. You're going to be pretty concerned about your statistical power. Then you want to see if there's any differential loss to follow-up between groups. And again, 10% or more may cause problems, and you want to make note of that as well. And I think you do also excuse me, want to make sure that intention to treat analysis was performed. Again, this is primarily for the superiority trials with binary outcomes. All randomized patients should be analyzed. Do they talk about how they handled missingness and their kind of imputation strategy, and and do you agree with kind of their methods? So all this should be explained. And then when you're doing your assessment, so low risk is if there's kind of either no missing data or very little missing data. And if the missingness is unlikely to be related to the outcome. You're worried about attrition bias, so you think there's high risk if there's a lot of attrition or it's differential between groups, or if the reasons for missingness are likely related to the outcome. And then, as we'll see is often the case, sometimes it's just not clear based upon what you're seeing in the paper. So just to summarize, attrition bias, can cause lots of issues and potentially compromises the randomization strategy. Again, you want to use this in superiority trials. And you can mitigate this using intention to treat analysis. Again, the primary method is also to try to just minimize attrition overall in the design stage. There are methods to include incomplete outcome data. So there's different ways to impute these data, but none are perfect, and especially if you have tons of attrition, that's going to be continue to be a real problem. And I think you just really need to kind of look at the specific study design when you're kind of looking at how these types of biases are affecting, the pension. Like I said, you do want to see how these relate to your outcome of interest, and how that may affect, how high risk of these biases and how big a problem they're going to be. So again, in your kind of chart that you'll be, kind of completing, assessing risk of detection bias. So was knowledge of the allocated intervention adequately prevented during the study? Yes, no, or unclear. And you're going to tell us kind of why. Was there high or differential attrition, and what are the outcomes? Incomplete outcome data adequately addressed and described appropriately in the paper. So that's it. We're going to go over this in class and do an example from a real trial, and happy to answer any questions when we see each other again. Thanks.